This conference will now be recorded.
So, good evening and welcome to Mission MRCOG class. This is a class for the part 3 orientation, and I'll be just explaining that what is expected from the students to get clear this exam, a bit about stations overview and tips and tricks. Okay, how to practice. And so this will be a detailed explanation about that. And any one of you, if any question is there, you can either ask me or you can message in the chat box. So it will be like a lecture, but to pass this exam, what is real important thing is to understand, okay, what is in the answer key of RCOG that will give you marks. Okay, it is not that your knowledge about any topic, no, the marking will be done what is written in their mark sheet. So to pass this exam, you have to have an understanding that what they want. Okay, you will speak what that will give you marks. So basically, if that understanding comes, so this exam is not difficult at all. Okay, so what is the key to success? Just find out what is there in their answer sheet and speak that and gain your marks. So please understand the expectations of RCOG. I'll try to give you the overall picture about it. Okay, so first nobody will be going to ask this training pathway in the exam, but it is important that you should know this, that how the training happens in UK. Uh, if a obstetric team is there, if a gynae team is there, how many people are there, and what type of work they can do, what are the competencies are there, whom they have to report, whom they have to call, because when they are taking exam, they don't know you are overseas candidate. So questions for UK and non-UK candidates are same. So you have to make a picture in your head and understand how the things work there. Then the answering your question will be easy. Okay, so they have a foundation, foundation years. You will find FY1 and FY2. This once the foundation is done, after they complete their medical school, then they have to decide, okay, what they really want. Those who want to choose OB gynae as their career, so they have a women health training module, so they have to do that. Okay, so after doing that, so then they will enter into the gynae program. So 1 or 2 year will be their basic training. Okay, then 3 4 and 5 years is the intermediate training. 6 and total training is period is 7 years. Okay, so and advanced training will be 6 and 7 years. So it is a 7 years program. So where like when we give part 1 exam and when we give part 2 and 3 exam, so after this basic training for 2 years is done. Okay, so this is core training. When this training is done, then they will appear here. Okay, they will appear for MRCOG part 1 exam. So this is this place, they give MRCOG part 1 exam. Then they will have a OB ops and gynae training for 3 years. So this is an intermediate period of training. Like in our all countries, we do have this 3 year post graduation training program. Same is that intermediate training. Then once this training for 3 years is done, then they have to complete MRCOG. So this part, this is the after 5 years of training, or after 3 years of intermediate training, they have to pass this MRCOG, complete MRCOG. So part 2 and 3 exam lies here. Okay, so when we are appearing for the exam, so expectation from us students is to behave like a postgraduate student, final year postgraduate student of our countries. Okay, so then why it is understanding is important, because some of the people who are giving exam, they may be consultants in their institutions. But no, you have to lower down your training, and you have to come to the level of P3 or postgraduate third year. Okay, because they are, you are doing exam at that level, so you have to behave like that only. You cannot, so there will be many case scenarios where the calling consultant is necessary, and those who are working as a consultant, they have a very difficulty even just to say call for help, or just to say that I will inform my consultant. And these are the communication that carries a mark. So though everyone is giving exam here, so those who are in a higher level of training, they have to be here. Okay, so therefore understanding of this is important. Fine. So, like this is the basic training for 2 years, foundation year one or foundation year two. So this is FY1, FY2. So they will do women health training, women health module. Okay. So this is the one snapshot of training health module. Nobody is going to ask this in your exam. It is just you have to know this. After that, there will be core training. So core training will be like ST1, ST2. So this is basic grade. 3, 4, 5 is intermediate grade. Most of the work in the hospital done by these people only. We already know from our hospitals also. So they are the responsible people for patient care. ST6 and ST7 will be advanced grade. Okay, so what ST1 and ST2, like what they want that ST1 and ST2 should be knowing. In they have got a training matrix and training curriculum, and this get updates every year. So they have to, in their training curriculum, there are certain courses. So these courses has to be done by ST1, and in their curriculum there is a competencies, so they have to show their competencies of that level. Apart from this, everyone has an educational supervisor and also e-portfolio. This e-portfolio is like the kind of like e-book, where what are the updates of their training they have to put in it, and it is accessible to some of the people. Their training, their educational supervisor, and also like some of the other seniors. Okay, so some part of the portfolio will be accessible by by some educational supervisor, and some part will be accessed by the college tutor. So there is a e-portfolio. In our UG and PG days, we used to make a logbook. Okay, but it is not like a logbook. It is a more advanced e-portfolio. Why this e-portfolio is important for you guys is to, you have to, whenever a teaching station comes, so whatever they are teaching, so it is adding to their knowledge, so they have to put in their e-portfolio. So this much little bit knowledge is necessary about e-portfolio. And ST1 and ST2 has to part their part 1 exam. Okay, now we stand here. Okay, so there are 3-year training that is called intermediate training. There are certain courses so that you will find in a RCOG curriculum, and certain competencies. According to the competencies, what are supposed to know at 3, 4, and 5 level, that much work only we have to do. Okay, so the thing, it is totally planned according to curriculum. Competencies has to be done, then only they will progress further. For them also e-portfolio, and after intermediate training is complete, they have to do a part 2 and part 3 exam. So we stand here. After completion of MRCOG, some of the doctors, they would like to go for advanced training. So then their advanced training or super specialty training. So it starts. It is for 2 years, and ST6 and ST7, two people, like two grades are there. These are advanced grade, and they have to do certain modules. There are 80 SM modules. Even if you find strategy, so you will see that these modules are there. Okay, so these are advanced training skill modules. Only you just know the names because it is not required in the exam. Okay, and these are the 4 fields subspecialty training is provided in UK. Gynae oncology, and this is fetal medicine, reproductive medicine, and urogynecology. Okay, need not to remember anything, just you have to have an idea of their training program. Fine. Now, this is all about their training. Now, you have to know uh, about the exam, because if you know what they want in the exam, so you will train yourself in that manner. Then, and if you know what they want, and if you train like that, so you will pass very easily. Okay. So usually what really happens, so there are 14 modules are tested in part 3, and from each module you will get one task. So total number of tasks allotted are 14, one from each module, and the time allotted to one task will be 12 minutes, but you will not get all these 12 minutes. There will be there are certain 14 cubicles are set for the exam, and outside cubicle there is a standee. Okay, on this standee, on the standee they usually write the your question or station. You will find 3 4 pages there, so you will get 2 minutes to read that, and also you will make your plan that what you will go what you have to do in next 10 minutes in this station. Okay, so these 2 minutes are the lifeline, and if you plan your station well, 2 minutes, then your performance will be going to go very great, okay, in 10 minutes. So this is reading time, and this is performance time inside the cubicle. And total time for the exam is 2 hours and 48 minutes, so you are just running, only you can breathe, that's all. Now, what will be the type of task you will get? Okay, so there will be three kind of tasks. There will be simulated patient task, and there will be simulated colleague task, and there will be case-based discussions. So what is a simulated patient task? This is role player task. So you will in this type of task, you will find three people sitting inside the cubicle. I will explain whom you will get. Then simulated colleague task. What is that? Usually it is a teaching task. So you will get your junior sitting, and you have to teach him or her something. So this will be simulated colleague task. Third will be case-based discussion. So these are viva stations. It could be interpretation of certain charts. It could be any patient-based discussion. It can come from anywhere, and their total knowledge. Okay, you have to show your real knowledge in case-based discussion, and you will find only one person sitting in the cubicle, that will be your examiner. Fine. So yeah, why I just want to say one thing here. So many people, they make mistake. What mistake usually people make? They will not read the station very well outside, and because that so much of tension is there, and 2 minutes, so people will do simulated colleague task as a simulated patient task. Okay, so you never people, they didn't read their the task well, and they did colleague task as patient task, and patient task as colleague task. So this mistake can happen. So you people have to real careful that what type of task you are getting. Case-based discussion task, only examiner will be there, so chances of making mistake are very less. Now, this they do have a closed marking system. So now you have to understand their system. This is how the marking is done. Usually, it is not like 20 marks or 40 marks station, or you will get 35 or you will get 25. It is not like that. Total station is marked according to domains. Okay, there are 5 domains that has to be marked. I will be explaining that as well. So now, for example, if the patient safety domain is there, so they will, in their mark sheet, they will be, it will be written patient safety, and there will be at least 5 to 7 points in patient safety, or 8 points, like this is like that. And if a person, he is speaking in the station, like 6 to 7 points, so he has covered most of the point in their mark sheet, so he will get 2 marks. Now another person, a candidate, she has or he has spoken only 5 points in patient safety, she will get 1 mark, borderline. Her patient safety marking domain will become borderline. Another candidate, like he speaks in the patient safety, but he or she speaks only 4 points in patient safety, so he will get 0. Okay, so this is, bad marking system, but we can't help it. It is their marking system. It is UK based exam, and you have to understand this. So like in our countries, when we used to give exam, if even we are speaking 3-4 points, ex examiner used to give us marks. It is not in UK, friends. Less than 5 is 0. 6 points, if a person is speaking, is borderline. More than 8 or 8, it will be maximum, so he will get complete 2 marks. So similarly, this is the close marking system. So we have to do very less. We really can't help it. So if we have done, we have spoken 3-4 points, so we get 0. So this is bad marking system, but it is there, and we have to understand this. So every station, there will when you will go in the exam, you will find that this task will assess clinical skills in following domains. So you will find domain list. So that means if the 4 domains are tested, so that means that station carries a 8 marks. Okay, now how much you have spoken in each domain, according to that marking will be done. Okay, so after 14, now this is the per station marking, and after whole exam is done, then there will be a global marking. In this global marking, they will like globally assess a candidate, that how he is doing in all stations. So you know all 4 domains, if they are borderline, they can give candidate a pass marks. But if a candidate is borderline in patient safety, they will not give you pass marks. So out of 5 domains, one domain that must to pass is patient safety. So now you people can understand that patient safety is very important. Now you will have an query, or you will think, what is this patient safety, why it is important, and we know patient safety, we are a safe doctor, but for the sake of exams, what we have to put in that answer, so they can give us marks in patient safety. So the things are not that difficult. I'll try to explain you about that also. I will be explaining much details in patient safety in upcoming slides. So these are the modules to be tested. So core surgical skills, post-op care, antenatal care, management of labor, management of delivery, postnatal care, maternal medicine, teaching, general gynecology, subfertility, oncology, urology, sexual and reproductive health, and early pregnancy. So you are going to get one station from each module. Okay. So some people will say, okay, I don't like fertility and I won't read fertility. And you just pray to God, hope that question doesn't come. But that era is over, because it has become module based. So you can't leave even a single part of your syllabus, whether you like it or whether you don't like it. You have to do it, because you are going to get station from each module. Now, type of examiners. So it is new to this part 3 exam. uh, Clinical examiner are the doctors. Everyone knows that, but there are certain other examiner is also there, that is lay examiner. And who is that lay examiner, and what is the role of lay examiner? So in the role player station, so this will be, you will find this is the cubicle for role player station. Okay, so you will find 3 people sitting there. So one will be your clinical examiner, we already know the doctor has to be there. And this clinical examiner in role player station, he will not look at you, you need not to interact with him. He'll be just sitting in one corner and just marking. Okay, so you are not any time you're not like involved with this person, clinical examiner. Then you will find second person, and the second person will be lay examiner. Okay, who is that lay examiner? This lay examiner, usually these are the people from community. For example, if endometriosis station is coming, they have a endometriosis pain society, so she may be one of the women from that group. Okay, there can be teachers, there can be lawyers. So all these people, they are the lay examiner. So what lay and this lay examiner has to do, and why, what the things they mark on. Okay, so this lay examiner will, they will see few things: how you are coming, how you are sitting in the cubicle, how you are making rapport with the role player, whether you are answering her concern, whether she has said something, whether you are making faces, whether you are judging her. So all this stuff will be seen by lay examiner. Okay, so there are certain points you have to keep in mind to gain marks from lay examiner. So if a role player station will come, so three in role players in role player clinical examiner will be marking at least 4 modules in role player station, and lay examiner, she will be marking your this thing 3 modules. And usual modules that are marked by lay examiner will be communication with patient and colleague, communication uh, with patient family, and also they mark on information gathering, the way you are taking history, the way you are responding. They have got no role in patient safety and applied clinical knowledge, because they are not deal with that. Okay, so and in a what I have gotten information, if there are 2 examiner, if your clinical examiner gives you pass mark and she gives you gives a candidate fail marks, you cannot pass that station. But if it is the vice versa, she has passed you and she clinical examiner, he has not given pass marks, then you still pass a station. So she's a real important person in the role player station. That's emphasis I want to give. And you will find one a role player. So in the role player station, you have to interact with the role player only. These 2 people will be just, observing your she will be observing your actions, and clinical examiner will be marking you. Okay, so this usually happens with the role player station. Therefore it is important, please don't mess up which is a simulated colleague patient station or which is the simulated uh, patient station. Because if you do mess up, then you will lose that station. Now, these are the domains. Okay, so marking will be done according to domains. So you will find if first page of your exam, it will be like this is the simulated patient task. Marks will be allotted on following domains. So then you will find 3 or 4 domains will be there: patient safety, information gathering, applied knowledge, communication with colleague. So you will get 3 or 4 domains. And then when you answer that station, you have to put all the points that are required in that particular domains in that particular station. Okay, so exam is not difficult. We already know, we have been studying for so long, but the problem is the marking. What they want to listen from us in patient safety, you have to speak that to gain marks. It is not like what knowledge we have. So it is important to know. Now, domain number 1 is the patient safety. Now, by the time you all of you must be aware, so that patient safety is utmost priority. For your clinic's practical purpose also, and for this exam it is must. You have to get patient safety globally passed to pass this exam. Now, what are the points? So uh, initially when you people will start doing practice, so you will wonder, okay, what is this patient safety, what should I put inside the station to gain those marks. Okay, so some part of the patient safety will be in history, some in patient safety will be in examination, some will be in investigation, and some will be in applied knowledge part or the management part. So patient safety points, you have to almost 80% of them you have to bring in the answer to gain marks. Okay, otherwise getting marks is difficult. So the good idea would be, like, you can make points or for what to cover in patient safety, and whenever you are doing stations or you are practicing with your study, body, then you just see whether you have put that point inside in or not. This is the only way you will assess yourself. Yeah, I have put all patient safety points inside the station. Okay, so I would give you most of the patient safety point here, but every station will have different points. So I will give you the overall picture. Fine. So what the GMC says, maintain patient safety and dignity has to be maintained all the time. Okay. So what is this dignity? So like for example, cord prolapse is there, and you are shifting this patient, so you have to make sure that the dignity of patient is maintained. She's properly transferred or covered, or all this stuff is there. Okay, so but dignity, safety we are doing, dignity is also important. Now call for help. So this is again, when you are dealing with an emergency, you are dealing with APH, PPH, patient, your patient is collapsed. In that particular situation, these are emergencies. So in obstetric emergencies, in gynae emergency, just you, if you speak out, call for help, you will get 2 marks. 1 mark you will get in patient safety, because you know your limits, that you won't be able to deal this emergency alone, and you will get 1 mark in communication with colleague. So only speaking this call for help will give you 2 marks. Okay, one in patient safety domain and one in communication with colleague domain. But this is so simple thing, and when we do station, we just miss this simple easy thing. Therefore we have to understand where the marks are there. So this is a call for help. Know your limit. So I just said that you are giving this exam as the final year postgraduate level. So what are your competencies? Only that much work you will do. If something major has come up, you have to call your consultant. If it is not there in the hospital, so even you can call him, or otherwise on call consultant will be there. So please don't forget your consultant. You have to work within your limit, because you are not a superman. For this exam, you are only ST5 only, ST5 or year 3 postgraduate student. Now confidentiality, many of the stations you will find confidential information, and you have to assure this to the role player, then only she will speak. So this is a very important part. And to maintain this confidentiality, and also you have to have a knowledge of data protection act. Okay, because in some of the station you have to use this, and patient any record paper, any image, electronic image, so all these things cannot be shared. We know this is a patient safety, and this is a maintenance of confidentiality. Okay, some of the station will have you have to bring confidentiality in this in the station. Okay, you have to speak this to the role player, then only you will get marks. Now duty of candor, what is this duty of candor? Something has gone wrong, some complication has happened, then you can't just go and say, we tried our best but this happened. No, this thing is not done in UK. You have to, what you have to do is a duty of candor. This word you have to speak if you are doing Viva station, and if it is a role player station, so you have to bring all this in the answer. Like you have to speak to the role player about all these 5 points, then you will get marks in duty of candor. Okay, so you have to be open and honest. Like what, you can't just patch up for the thing for the that the complication had happened. You have to be real honest. What are the complication had happened, and what are the steps you took to manage that complication. You have to give a factual explanation. Then out of that complication, what will be the implication? Short-term implication, her hospital stay will increase. What could be the long-term implication? Okay, then whether you want to put up her for any follow-up with a gynae team, or if the ureter injury is there, with a urogynae team. And also you have to bring that investigation, internal investigation, or the incident reporting, risk management, root cause analysis. So everything will come in the picture. So if you're getting station for uterine perforation, if you just go and say, see, sorry, it happened, and we took all the measures so to avoid it, but it happened, you're not going to get marks there, because that is not complete explanation of duty of candor. So these 5 things you have to bring, friends, in the answer of a complication station to get complete marks in duty of candor. Therefore, knowing it is real important. So you have to explain this to the role player in complication station, and if it is a viva station or case-based discussion, then also you have to speak about that. So it is important to understand duty of candor. Now, another patient safety points, undermining of your colleagues. Okay, so in UK, according to their working culture, you can't undermine anyone. So if I'm your junior, I have done some mistake. So you can't say in front of the examiner, okay, yeah, I know she's a junior one, she doesn't know how to work. So no, you can't say this. That will be undermining of colleague. Or for example, in one of the station, like role player said, GP has said that a hysterectomy will be an option for me. She was a patient of heavy menstrual bleeding. So in that particular station, so it is an exam station, okay? It came in November 2018 exam. So you can't say, GP doesn't know about it. That will be undermining of your colleague. GP is your colleague. So what you have to manipulate the situation. What you have to say, yeah, hysterectomy is an option, but there are other options as well. If you would like, I would discuss about them. So in this way, you have saved the skin of your colleague, and you have not undermined them, and also you have spoken about the options what this patient have. So it is important to understand this, then only you'll be able to put in the station. Fine. Then mental capacity assessment. It is real important. Where it is important, like whenever you are doing these consent stations, so there you will require a mental capacity assessment. Apart from this, there is a station where this patient has Alzheimer's, okay, and her daughter is coming. So you have to do some certain things there to put the answer of that station. So some issue like how the capacity assessment will be done, who will whether the best interest meeting will be done, what will happen. So all these things you have to bring in the answer, then only you will get marks for patient safety. Another point will be the Fraser competency guidelines. You know everything. Without that, how you can pass this part 2 exam? So sometime you will find a 15-year-old girl, mom will come and she will say, doc, what you have done, what kind of doctor you are, you have given my 15 years old daughter a contraceptive pill. How can you do that? So this is a complete whole station, and you have to just all the 5 points of Fraser guidelines you have to bring in the answer. Okay, so there is a complete station about Fraser guideline. Fine. Then chaperones. So just speak this word chaperone. Okay, chaperone or healthcare assistant. So just speak you one word there during examination of the patient, and you get a mark in patient safety. Okay, then respecting their cultural and religious beliefs. So like for example, most common thing that comes up in the exam is the Jehovah's Witness. So whenever you think you have to give blood to that patient, you always take care and you have to ask, have you got any objection to blood? So if she says yes, you can't give that patient blood. So some of them will have some other beliefs. So whatever they believe in their culture or religion, you have to accept it. Okay, that is a patient safety. Then if you are dealing with an antenatal patient, finding and identify that this pregnancy is a high risk pregnancy. Your patient is smoking, patient is taking alcohol, she is on drugs, so she is a victim of domestic violence. So all this, if you are identifying in a station, then you will get marks for safety, because management accordingly will be different. And if any child abuse is there coming up, so you have to find that up, then only you will treat them. Any rape patient is coming, or any FGM patient is coming. So you have to identify them from, because in the station outside they will not write you are dealing with rape, FGM, or child abuse. It is your duty as a candidate to find out that. You have to find that out, and accordingly you have to do that station. Okay, so this will give you marks on patient safety. And very difficult station to identify will be if your patient is a victim of domestic violence. Okay, because they will take all like all other ways to hide that, and your job will be to find it out. Many times station had come and people have missed to pick that domestic violence. So identification, if you identify high risk pregnancy, domestic violence, child abuse, rape, FGM, then only the treatment will be done accordingly. Otherwise, if the patient comes with any other complaint like I am having pain abdomen or any other complaint, you will treat her problem, but her problem behind will be left unattended. Okay, so at this identification is real important. Now this is again a list of patient safety. So if you are having a station for the pre-op surgical module, you have to bring WHO safety checklist in the station. This will give you marks. So patient safety checklist, even you have to read it completely by heart, because a number of station revolves around this safety checklist. Then checking for allergy, all 14 station, this word allergy is so important, and they're so fond of bring like listening to this word. You have to bring all 14 station, allergy has to come out from your mouth. Checking of blood group. Okay, whenever any intrauterine procedure you are going to do, like histros, you are sending patient for hysterosalpingography, or you are sending this patient for hysteroscopy, you have to make it sure this patient is not pregnant. Okay, so checking pregnancy before any intrauterine procedure, or before any surgical procedure will give you marks on safety. Fine. Now, in the exam, sometime you have to prescribe some medication. So, what is important? You have to know. Important part, you have to know whether patient has got any contraindication to that medication. For example, a station had come once whether the patient has this antiphospholipid antibody syndrome. So your treatment, what you will give as a treatment, it will be aspirin and heparin. But if you see her checklist, you will find she is allergic to aspirin. So in that patient, you have to modify. You can't give them aspirin. You have to give only heparin. So whenever you are prescribing, friends, any medication in the station, please check for allergy. Okay, please check whether this patient has got any contraindication to that particular medication. That is patient safety. And if patient has associated comorbidities like renal disease is there, liver problem is there, so you have to take care of that particular drug. And whenever you are prescribing any drug, so you have to know the dose and the route, which route you will give. Some of the drugs will be affected by BMI of the patient. For example, you already know heparin, so you have to know BMI of the patient. Then only you can do the dose calculation. Sometime patient will be taking some enzyme inducers. Most common is these patients will be like in the exam, some it will be epilepsy patient, they are taking some inducers and you have to give contraception. So you have to really take care of this enzyme inducers. Therefore asking what they are taking, the medical history is really important. Then if your role player is pregnant and you are prescribing any medication, please look for the safety, whether it is a safe drug in pregnancy, then only you can give. Then if your role player is breastfeeding in postnatal module station, you have to check whether that drug is safe in the breastfeeding or not. Okay, so with the medication, so much thing is required to gain marks in safety, so that you have to understand this. Now prioritization and trial. So UK people, they are fond of this prioritization. Prioritization means that you have to do urgent case first, you have to do semi urgent case later on, and routine case when you are free. Okay, so this way prioritization is done, that is the urgent, semi-urgent, and non-urgent. And you are the person who are in charge of the labor ward, so you have to take leadership quality. They are checking your leadership quality and also how you work under pressure. Okay, so prioritization station, full complete station will you will get in labor ward, and also you will get gynae ward prioritization as well. And they're so much fond of this prioritization. Last November, all for 4 days, labor ward prioritization they kept. Okay, so one station come from labor ward, and that was prioritization all 4 days of the exam. So they're so fond of it, and you have to prepare it and do it real well. Now, another part in the patient safety, like if you are find that anyhow in your uh, patient, you are getting a cancer patient, you are making a referral. Okay, so please try to bring this 2 week wait pathway, because usually the cancer patients, they are seen within 2 weeks. Okay, so you have to bring that to get answer marks in the patient safety. Then you will find some station that will have a work based assessment, some OSATs will be there. So you have to have a knowledge about that. And safeguarding. Okay, sometime you will find adult safeguarding you have to bring in the station if the domestic violence is there. Sometime you will find child is at risk. Okay, so then child safeguarding will come. And this is real important to bring up that safeguarding thing in your station. Okay, so apart from this, these are again the patient safety points. Risk management, it is real important. So sometimes you will get find a complete station about risk management. And if you're not finding a complete station, but in every station somewhere there will be mark for risk management, because some risk management issue will be there in the exam in that particular station. So you have to identify it, and you have to bring in the answer to gain marks. Okay, so following protocols, their system works with a protocol. You have to follow that protocol. Audit is a station. Reflective practice is a station. Incident reporting, anywhere anything had gone wrong, you have to report that incident. Root cause analysis, again, that is a station that comes along with risk management. E-portfolio thing, I have already explained. And if any like retained swab has happened in the surgery or in the tear in the vagina, so that is a serious incident. You have to identify that, you have to report that, that is a never event. So that will bring you marks in the patient safety. Okay, so these are the these are the complete checklist what I was able to make for the patient safety points. Okay, so what you can do, you people can make a complete note for the patient safety point, and whenever you practice with your study friends, then you see whether you have brought that patient safety point in the answer or not. Okay, so again, there are certain pitfalls in patient safety. So what is the pitfalls? Okay, if you're not understanding clinical governance, I already explained you risk management, clinical governance, audit, reflective practice, and protocols. So if you're not bringing that in the exam, okay, so you're not bringing the answer because you don't understand that. So this is the common mistake people do make. Then you're not able to, you're not if any complication is happening, there had been so much PPH all the time. There is something problem with the trend going on in the hospital. You have to do audit. Okay, so you have to identify it in the station and bring it. Then you're not understanding the duty of candor when the care falls short of care. I have in just saying sorry is not enough. You have to bring all 5 points of duty of candor to gain marks. So these are few of the pitfalls in the patient safety where candidates they do make mistake. Okay, so that's all I have to speak about patient safety. Now if any one of you have got any question about patient safety, can tell me before I move to another module. Any question with regards to patient safety? Any one of you, any question with regard to patient safety? Any question? Okay, any question with regards to patient safety? Okay, so if there is no, okay, somebody has messaged. Okay, that's good, great. At least you have to give me some answers, Otherwise, to me, it appears that I'm speaking to myself. Good. So, friends, understanding these points of safety is important. If you know those points, then only you will try to bring that in the answer. Now, we move to domain number 2, that is the communication with patient and the family. Okay. Now, so in the whenever this is coming, usually these will be tested in the role player station. So role player station, you have to bring in the picture is the ice. What is this ice? It is idea, concern, and expectation. Like idea is what is their, they have idea about their problem. Okay, what is their concerned about, what is their expectation out of that consultation. Okay, so I can give you an example. For example, a patient of heavy menstrual bleeding has come. Now she is bleeding, so you can but on the other side she has got some other problem also. For example, she had any ovarian cyst also. So now she has come for the heavy menstrual bleeding. So when you are explaining her about her diagnosis and problem, then you can just ask her, have you got any idea what could be the reason behind? Because something is running in their head. So you have to ask their idea. Okay. So and concern, so the patient has, you have to ask their concern. So what are the things that bothers you most, why you are concerned about. She has come with heavy menstrual bleeding. You are speaking all managements according to nice guideline about heavy menstrual bleeding. At the ninth minute of the station, now she will if the role player says, doctor, I'm not concerned about this bleeding, I'm worried about this ovarian cyst. It could be a cancer. Therefore, I have come to you. Now, you have not asked her concern in the beginning. You are asking that at the ninth minute of the station. Now, if your role player concerned are not answered, whatever you do, you are not going to get marks. So please check for her concern. Why both of you are there? What bothers her? Okay, what is her concern? Fine. Then they will, you have to ask like what are your expectations. Sometime you will say a treatment option will be, medical and surgical. You are speaking about surgical thing. Okay, maybe she doesn't want to listen, that she has come for medicine. So you ask her, so what you are expecting out of today's consultation? Or so she will say, no, no doc, I don't want any surgery, I'm looking for medication. So you have asked her expectation, so speak about that. Okay, so all role player station, you have to bring this ice in the station, uh, because you have to check their idea, you have to check their concern, and also your expectations. Okay, so all these thing is real important, because patient has got their autonomy, whatever they think, it is their idea. Then in the role player station there will be certain emotions, you have to acknowledge that, and active listening is must. So whatever the role player is saying, okay, so you have to respond, you have to say yes, yeah, I understand. So this way, otherwise to role player, it will appear, if you don't do this, that you are not concerned about her problem. Okay, so this is ice, and this ice has to come in all role player stations. Now, what are the tips for communication? Self introduction. Okay, so station usually start that you have to introduce yourself many times. This is the simplest thing that you do when you enter in the station. Then usually you have to, people in a confusion, stress of exam, They will not introduce themselves. Okay, they will not introduce themselves. They will not speak about their role, and they not speak about their job title. So if like this way, self introduction is must. Fine. So you have to speak, introduce them with your name, whether you of your role, whether you are a doctor, or you are trainee doctor, or you are a consultant. Job title is always must. Second, you have to always confirm their name and age. So always when we start station, we just say, I can I confirm your name and age, full name and age, please. Because if she is Jane, so there may be 100 Jane. So identity confirmation is must. That will give you mark in the patient safety. Age is real important, because a role player, what they are sitting, they will not look. If the station has got like a patient who is 40 years of age, you may find a 20 years old girl sitting there. So looking at their face, you cannot find out the age of the patient that you are discussing in the station. So asking age is really important. Okay, then you have to make rapport with the patient. So then whenever you have to keep involving patient at every moment. So when you are taking history or you are doing information gathering, every time you are speaking, a role player is speaking, you are speaking, role player is speaking. But after that, usually what happens, it becomes a complete lecture when you discuss investigation, when you discuss treatment, and when you make some decision for them with their involvement. Okay, so for communication, you have to, communication is two-way. So you have to keep involving your patient all the time. So after your history is done, whenever you are about to discuss diagnosis or the investigation, so just take her permission. Would you like to discuss your test results today? Okay, that is involvement of patient. Then after investigation, now you are heading towards the treatment. So again, you can take permission, or you can involve that patient. Okay, would you like to discuss about the options what we have to offer for you today? So like this way, keep on involving the patient. Otherwise, after information gathering or history taking, it becomes a complete lecture. So maybe you will get mark in applied knowledge domain because you have managed your patient well, but another domain will suffer. That will be the communication with patient, because you have not involved that patient at after the information gathering. So involvement of the patient for whole 10 minutes in the role player station is real important. Then shared decision and patient centered care. So I will explain what is the shared decision. Actually, in our countries, most of the time, what happens when the patient comes, we just write the treatment, and what we say, okay, this is a treatment for you, this you have to take. But the things are not there same way in UK. In the UK, what we really have to do, it is we have to give them choices, or we have to give them option. Now it will be their choice what they will decide. So you what is a shared decision? So you have to inform them, you have to explain them. Engage them means explain them what are the risk and benefit of that particular choice. Then there will be some kind of negotiation, and some treatment option they would agree with. So that will be negotiation. So in the your management part of the station, it has to be shared decision according to her choice, according to her belief. So you have to inform her about options, you have to engage her, speaking about risk and benefits. Then with the negotiation, something will come up. For example, I just want surgery as my treatment, and you want to offer me medication. So there is a mismatch. So what you as a doctor has to do, you have to speak me about the risk and benefit of medicine, risk and benefit of surgery. Then I may think, okay, let's try medicine first. So this will be kind of negotiation. So this way the things happen. So doctor in the UK, they have to give only options. It is a patient who will decide. And why therefore I have put this slide here. So this is the screenshot from the RCOG information leaflet. Towards the last page you will find this box. So now see, it is a shared decision making. What are my options? What are the pros and cons of each option? How do I get support to help me make my choice for me? Okay, so we as a doctor, we are telling them options, we are telling them risk and benefits, and we are supporting them to decide the best option of management for them. So if you understand this, then only you will be able to like bring this in the answer. Fine, so this is a shared decision making where it is a negotiation between doctor and the patient, and it is a right of the patient to decide what she wants. Okay, then they will mark in the communication with the patient, they will mark you how you are as a doctor, how you behave in the crisis time. If some IUD had happened, if any fetal distress is there, if you have to break the, if patient is collapsed, how you will go out and speak to her husband or her partner, whether you have to break the news of a cancer. So they are seeing your communication in the crisis also. And if the rupture topic is there, so stillbirth station is there, collapse station is there, and rupture ectopic station is there, and breaking bad news station is there for cancer, and fetal distress is also there. So every, they will put up a scenario of these, and they will see how you're communicating in this crisis situation. This is these are these stations are a bit tricky and difficult station. Sometimes your role player will be crying, sometimes they were sad. So you have to real do the practice, otherwise it really becomes difficult. Because if you see a crying patient or role player in front of you, half of your energy will go, if you see any that type of patient. So to calm your nerves, you have to real do practice in with your study partner. Now, communication is not what is only speaking, it is non-verbal also. So today what communication I'm doing to you is only verbal, because my camera is not on, and you are not able to see me what type of involuntary movement I'm making, whether I'm shaky, whether I'm inconfident, whether I'm doing any other thing. So what we are doing right now is the verbal communication, because you are listening to me only. So non-verbal part is not there. But in this is a name, not the scenario in the exam. In the exam, you're sitting in front of your role player. So both you will be marked for your verbal communication and your non-verbal communication. So I won't be discussing it too much. Few things you have to understand for this communication. So if the verbal communication is there, whatever you are speaking, speak clear. Okay, accurate. You have to give accurate knowledge, and you have to keep on changing tone of voice. It is not the monotonous tone of voice, like in a same tone of voice you are doing whole station. No, it goes ups and downs. Okay, so everything is marked in this exam. How is your tone of voice, and what type of language, what type of you are changing according to the patient age, language, level of understanding. Like the way you do station, if the 15 years old girl is in the station, and the way you deal with the patient who is 60 years old, the way you deal with the patient who has just lost her baby, bereavement station. So everywhere your body language, your verbal language, so everything will change. And the skiller lay examiners are sitting, so they are checking everything. So speaking part is still easy, okay, because you are speaking, that is in your control. But you have to really speak clear, and you have to have a change in the tone of your voice. Okay, now this non-verbal communication, these are the non-verbal communication. And this lay examiner, she will look all these things, your body language, like how you are going inside the station, whether you are frowning, raised eyebrows are there, whether you are looking confident, whether you are being nervous, whether you are panicking, whether you are sweating. The sweat doesn't come in UK because of the temperature. So overall from your face they will be able to find out that what type of person you are. And who is looking that? This lay examiner is looking on that. Her work is only to look at this much only. So she'll be completely taking care of all these issues. Therefore this exam has become a bit difficult. Previously these lay examiners are not there, only clinical examiner is there, so he was marking for verbal and non-verbal thing, so things were easy. But as the lay examiner has come, so they see everything, all facial expressions. Then sometime you have to touch a patient, so it is not must. If you are comfortable, then only. For example, she's a crying mom, then you can pet her back. But if you're comfortable only, this is a non-verbal communication. Eye contact. Every time whatever you speak, you have to see in the eyes of role player. Eye contact is must, okay? Otherwise they will think that you are not interested. Then your posture has to be confident, and you have to sit within a welcoming posture. And what is a welcoming posture? That you are sitting with in front of the role player with your arms open. You cannot cross your arms, okay? So that is a closed posture, so you have to sit there with the open posture. Body language, it has to be a confident body language. So these are the non-verbal communications. You don't know, but what is the non-verbal communication, but these are the points, and this lay examiner is only looking at this. So you have to be very careful, because some of the candidates, what they will do when they are in attention, they start moving their legs. Sometimes they start petting that tabletop. Sometimes they will start moving their hands. So all these involuntary movements or unconscious behavior happens. So that will show that you are getting you're not confident. So all of this, you have to really keep your nerves calm during the exam. And you have to show yourself confident. Whatever will be the situation, please be confident. They are looking for confident and safe doctor. To pass this exam, two things are must: confidence and safety. Okay. So this part, it will not come when you are speaking, when you are doing the stations with your friend, because most of the time we are whenever you do on Skype or WhatsApp. So of non-verbal communication cannot be marked. So to mark a non-verbal communication, two way it can happen. You do a station, ask someone to record, and you just see your own video that whether what type of look you have, whether you appeared confident, whether you are making any unconscious movement. Or so this is the only way you have to judge yourself. Or when you do on-site courses means that you are going somewhere to do station course, then you will get this knowledge there also. So these are very important, because that killer role lay examiner is sitting to look at every non-verbal communication. So be careful. Now, what RCOG expects: empathetic and patient-centric approach. So in communication with the colleague, how you will get mark. So these are the point that will give you marks. If you are listening actively to this patient, like for example, I said this is my second pregnancy. So if you I already told you that this is my second pregnancy, and you are again asking me how many times have you been pregnant before. So this will be like that means I will get irritated as a role player, because you are not paying to attention what I said before. So this is a like active listening. Whatever she's saying, please keep your eyes and ears open, listen to her. You will get marks. Make your eye contact. Your eye should be you always, all the time you have to look at the role player's face. Okay. Empathy is a important thing, and every state not every, but most of the station you have to show empathy, and this will come with a real practice. Appropriate emotional response, like if your patient is pregnancy test has come positive, you have to do congratulation. But if someone has lost her baby, you have to be a sad person. Okay, you have to show that kind of serious look on your face. So appropriate emotional response. So these four things examiners are looking before they give you mark on the communication with patient. So what is the active listening? Building a appropriate rapport with the patient, asking an open-ended question. What is this open-ended question? I'll be explaining in upcoming slide. You have to be attentive. Like whatever she's saying, you have to listen. Should not ask that again. And you have to show a concern. You have to be concerned about the patient. If she's saying if some domestic violence has come up or anything has come up, you have to say, I'm concerned about your safety. I won't it won't be safe to go back home. So you have to show your concern that you are caring about that patient. So if, for example, if patient is having impending eclampsia and she says, no doc, I just want to go back home, you can't send her that patient back home. You have to show your concern. I'm concerned about you and your baby. If the blood pressure shoots up, something go, you may have fit, and you are a baby and you will land up in a trouble. So it is not unsafe that you should go home at the moment. So you have to show your concern that yeah, you're worried about her. So, and paraphrase, like if she says something, you have to say, yeah, I understand, it's okay, okay, it's great. Like this type of paraphrase you have to say, and you have to kind of reflect your feeling. So how the role player, if she's happy, you can smile. But if she's sad, you can't smile that time. You cannot show your teeth. So these are the few skills of active listening. Today it will be appearing as a lecture, but it all the points are real important, because this is one very important part that will give you marks in communication. What is empathy? That empathy, what you are feeling, I'm feeling the same. Or putting someone in your putting your leg in someone else's position. Okay, so this is empathy. So if you had a pain and I'm feeling that pain, that is empathy. There would be many stations where you have to show empathy, and if you don't show empathy, you will not get marks. So it's like for some examples I can give. So if your patient is in a pain, okay, you just enter a station and your patient is in a pain, just ask about pain, just offer some pain relief, offer some support, be a kind caring doctor. So that will be an empathetic approach. Now any other scenario, like you can just show your concern. What will be the most important thing that we can do for you today? And so whatever her concern is there, she will speak out to you. Then according to her need, if you do something, that will be showing an empathy. So in many ways, in many station, empathy will come, and with the gradual understanding, you will get to know that. What are the pitfalls? What are the mistake we do, that communication with patient domain? So no introduction, you are in at so much of tension, and you forget to introduce yourself, that yes, I'm Dr. Priyata, I'll be your doctor today. There is no introduction. Making assumption. So if she's a like patient with the, for example, 15 years old girl with any kind of chlamydia, and you are making assumption that she have like multiple sexual partners. So making assumption is again a very bad thing. Whatever she is giving information to you, whatever they have given in the question, only that much knowledge you have about that station. Don't make assumption. Then if you are feeling embarrassed about asking lifestyle questions, we have to ask about smoking, alcohol, we have to ask about mental health, we have to ask about domestic violence. So if you are, you're not asking question in a, you yourself are embarrassed. So that will how this lay examiner will give you marks. Okay, then you tell treatment, no, you're not negotiating. You just said to me, okay, this is the medicine I have written, you have to take this. So if you tell me treatment, you don't give me my option, there is no shared decision making, you can't get the marks. Then not listening. If I have spoken you anything and you're asking the same thing again, then you are not listening to me. So it is again pitfall in the communication. Then not respecting my belief. If I have got some belief, you have to respect that. If you're not respecting, then again that is a pitfall. Using jargon, this is a real important thing, because we as a clinicians or doctors, we are fond of speaking medical terms all the time. But this is part 3 exam. You're not allowed to speak any jargon. All simplified patient friendly language you have to use. Okay, so these are the few mistakes that the people do in the communication with patient domain. So if are able to find out your mistakes, then you'll be able to correct them as well. So communication with patient and families is an important domain, because it is tested from the moment you enter the station and moment you leave the station. So it complete 10 minutes communication is happening. So this is a domain that is assessed from complete 10 minutes. Then it do have a long learning curve. You can't do it in a single day practice, because sometimes you have to change tone of your voice, sometimes you have to show empathy, sometimes you have to show emotional response. So you will take time, but nothing is difficult in this world. Then if you are able to do well in this domain, you are going to get, because it is only communication speaking, so you are going to get complete marks. So please practice, speak with your patient, with your family, with your friend. Speak in a patient friendly language, because it will not come in a single day. So that's all I had to say about patient communication with patient and families domain. So any one of you have question can ask me before I move to next domain. Any question, friends?
No, ma'am. It's clear.
Clear, ma'am.
Thank you.
Clear, ma'am.
Okay, good. So the domain number 3, it is a communication with a colleague. Okay, so communication with colleague. So communication with colleague is not I'm speaking with you. There are so many communications. Okay, and communication in many ways, it is asked in the exam. Like there could be some written communications. So whenever the written communications are there, you have to write also in the exam. Some station will come where you have to write also. Your writing has to be legible and clear. Okay, whenever you are putting any entry, patient date, patient details of patient, uh, some uh, my voice, am I audible?
Yes, ma'am.
Yes, ma'am.
Okay, Sheena, you have to check your internet, because all other people can listen to me. Okay, so and whenever you are doing any entry, then you have to clearly sign all the entries. Then you have to avoid abbreviation. Okay, all the time this abbreviation should not be there, and you have to be familiar with the Data Protection Act. So these are the written communication. These are few rules of written communications. Now, what are the written communication will be asked from you in the exam? So there will be a consent station. You have to fill consent. So you have to take care of abbreviations and eligible handwriting, your name and your job title. You have to write a prescription. In prescription also, you have to write a complete prescription. Okay, discharge summary is in station. That is again, your junior has done something, like she had made a wrong summary, and you have to correct it. There also you have to, sometime they will give you a paper, so you have to write. Whenever you are writing, you have to, like you have to, it has to be clear. MDT letters are coming. These are also as a station. So you have to take care of that as well. GP letter can come, and post-operative note is a station. So these are the written communication. So these are usually asked in the exam. Most common of it is consent, discharge summary, MGT letter, and post-op notes. So these are the written communication that these are usually asked in the exam. Now telephonic communication, this is really important because telephone it is not like that no, it also has a pattern. So what is that pattern? You have to give information to patient in S bar communication tool. People know that, and you have to practice to bring any patient in this S bar. So what is it? This S bar is situation, B for background, A for assessment, and R for recommendation. Okay, so this is S bar tool. So what you have to bring in the situation, you have to identify a woman by the name, and you have to give me the reason for why you have called me. Fine. Then you have to describe your concern. So you have to say, I'm Priyata calling from labor ward. I'm concerned about the woman. She had a pathological CTG. So this would be the situation. I'm giving just an example. Then after situation, I have to speak about background. So like why this patient has been admitted, or any significant medical thing is there. So what I can say, she was admitted for delivery, or for the, and also she had a high blood pressure. So this is a background, some reason for the admission. Then assessment. Assessment means what patient is condition right now. Uh, it may be something about her vitals, contraction, what is the clinical impression. Okay, so this is in the assessment. And then you are calling me at the 2 a.m. in the night, so you have to clarify what you want from me at 2 a.m. in the night. So if you would like my opinion regards to some patient, so you have to speak, I would like your opinion with regards to this. Or you have to say, see, I want you to come in and join in theater. I'm shifting this patient to OR. Like what you want from them, so you have to speak it out. So this is the SBAR communication tool, and these are the things you have to bring in that. And telephone station is a commonly coming station in the exam, where your consultant Professor Hardy, he is sleeping at the home, and 2 a.m. you have to call him, and you have to explain him about some patient. So they don't want to they will not give you marks, like for just speaking that about a patient. You have to communicate to your consultant, you have to show your identity, you have to confirm whom you are talking to it, and you have to bring that patient information in this pattern. Then only you will get mark. So SBAR is a very important communication tool. Many stations it will be used. Then handover. So they are they are very fond of this handover or labor ward prioritization. So this part has to be involved. So what are the tasks that has to be done, what are the tasks has to be awaited. They are checking your leadership quality, team working. So they will give you a team that you have got ST1, ST2, anesthetic registrar, SHO. So you are not a superman or superwoman to do all the work. You have the team, you will get marks to involve your team. Triage and prioritization. Okay, so there is a handover station is also there, so that you keep usually coming. Okay, so Deepti, whenever you are calling your consultant, or whether you have a case-based discussion station, because you are communicating to a doctor, so you can use any medical terminology, and you have to use it in examiner station. You cannot use that patient friendly language, or like all this stuff will not come. It is doctor to doctor communication. You have to use medical terminology. Now nursing communication. So you will they have got nurse for everything, you know. So if you are getting diabetic station, bring in communication, bring diabetic nurse. If you are getting a patient who had a spinal cord problem, bring spinal nurse in the picture. If you are getting a cancer station, bring this clinical nurse specialist or Macmillan nurse in the picture. So these are the communication. Okay, so if you know them, then only you'll be able to put them in the exam. Okay, midwifery communications, for example, that you will get obstetric station, and in obstetric station how the things can be done without midwife. So there's many midwife will come. So there are junior midwives like trainee midwives as a doctor, there are specialist midwife, there are safeguarding midwife, there are domestic violence midwife, there is FGM midwife, and there is a consultant midwife. Macmillan nurses are the nurses who usually deal with the cancer patients. Okay, so this is the common name for like these nurses. And clinical nurse specialist will be again related to cancer station. She will be the person who will be arranging the care for that particular patient. You might have seen that in your ovarian cancer. If you go to ovarian cancer leaflet of RCOG, so you will find that clinical nurse specialist term there. Okay, so these are the communications, you know. So whenever you are doing station, all the time you have to scratch your head, and with the practice you will, without scratching also, you will get to know that whom I have to involve in this patient, because I am not superwoman. Now there are certain other communications will be there. So GP, if you get a referral letter from a GP, please inform to GP about that patient. Sometime, you know, you will find some stations where you have to involve counselor. Sometimes you have to take opinion from radiologist. These are all communication. Sometimes you have to speak to clinical secretary, sometimes reception people, and all the time maximum of station support group will come. So bringing all of them, if it is required in that particular station, will give you mark in the patient it will give you mark in the communication with colleague. Okay, and in the UK, multidisciplinary team is there, MGT. So you can't get marks if you don't involve them. For example, if maternal medicine or medical cases are coming, you have to bring MDT in the picture. You have to speak about the members of MDT as well. Okay, oncology cases, again onco MDT will come, and who are the people involved in that, you have to speak to that role player. Then if gynecology, for example, endometriosis is there, again there is a MGT, and who are the people involved in endometriosis and PMS, you will find that in the leaflet. Okay, so and you have to bring that in the exam. So whatever the station, if they demand involvement of multidisciplinary team, please involve them to gain marks. Now, so this in this exam, you know, you will not miss out any other domain, because you are speaking to this patient, you are doing information gathering, you are speaking to this patient, you are getting marks in communication, you are telling them management, you are getting marks in applied knowledge domain. Okay, so where and patient safety, you know, always it will be in your head, because patient safety will be checked all 14 domains. So what is the maximum miss out domain to gain marks is the communication with colleague. So please, whenever you read your task, look whether any marking is there for with the patient communication with colleague. If marks for communication with colleague are there, just look into it, just think of for a fraction of second. So whom which are the colleague I have to involve. So you just write it down in your on your paper, or just think about them and try to bring them all in the station. Why? Because you are just communicating to GP, you are just bringing a midwife in the picture, you are just bringing nurse in the picture, you are just bringing MDT in the picture, you are bringing urologist, continent advisor, fertility specialist in the picture, and you are getting 2 out of 2 marks, so it is very easy to get marks. So this is one of the table I have made, because this is like I find important, so I made it. So if any, these are some clues, if you are dealing with a fertility station, try to involve fertility specialist. If male infertility is there, you can involve a urologist or andrologist. So if you think fertility is, first you identify your station, then identify your module, your domain, and then identify that whom you have to bring in the station. Again, if the urology module station is there, you can bring urologist, you can bring physiotherapist or the continent nurse in the communications. Onco, I have explained about MGT. If antenatal station is there, you have to bring midwife in the picture. GP again. Emergency, this I have already explained. Any obstetric emergency, any gynae emergency, please call for help. And whom you have to call, please explain that to gain that complete 2 marks. If station belongs to contraception and sexual health module, please bring this contraception clinic or gum clinic or sexual health clinic in the answer to gain marks in communication. If PCOS station is there, try to involve endocrinologist. Menopause station is there, try to bring menopause specialist in the station. And you're not alone in the hospital, always think of your consultant, but you have to take a wise decision. For everything you cannot call your consultant or involve your consultant. And for some of the like tricky situations, tough situation that is beyond your competencies, you have to involve consultant. So with the gradual practice, you will understand where consultant is required and where consultant is not required. Because if you are the student who are calling consultant with every small little problem, so they will be annoyed. You cannot when even when we are doing duties in our hospitals, every time for everything we cannot call consultant. This way you can judge. Other communications could be counselors, support groups, geneticist, for example, a recurrent miscarriage station. And try to bring helpline in the picture. For example, if your patient is a smoker, please bring NHS stop smoking line in the picture. If your patient is taking alcohol, please bring drink line or any other helpline in the station. So these just identify your station, identify your module, think of your communication. And if you just bring those few names in the communication, you will get 2 out of 2 marks. So the communication with colleague is very easily missed out domain. And again, on the other side, it is very easy to gain complete mark, because only you have to communicate, you have to bring these people in the answer. That's all you have to do. So what are the pitfalls that happens in the communication with colleague? That you are not adopting a logical and reasonable approach for a clinical decision. Okay, you are struggling to find out a clear plan of action. Your structured approach is not there, like you're not using S bar, so some of the information is missing. In written communication, you have got problem with a logical thinking and eligible writing, and you're not understanding the role of MGT, okay, where you have to involve. So these are the pitfalls that you can have in the communication with colleague domain. So any one of you have got any question with this domain of communication with colleague, or should I move ahead? Any question?
No question, ma'am.
Okay, so question number, domain number 4 is the information gathering. So what is this information gathering? Information gathering is nothing, but it is your history taking. Okay. So again, so what the GMC want, that is a duty of a doctor, that doctor has to adequately assess a patient's condition by asking history and about her symptoms. So therefore, information gathering is really important, because with that information only you'll be able to diagnose that what you are dealing with. So during information gathering, you have to do signposting. Okay, what this signposting is, I would just explain. Your approach is a holistic approach, that like if I am having problem with the pain, and on the other side I'm living alone, I'm a single mother, so you will not deal only with me, my pain. You have to offer me support also, because I'm a single woman taking care of my children. Fine. So it is the holistic approach. You have to offer them complete care. So you're not looking only at the medical part, you have to look at the non-medical part and the safety of patient as well. So you have to it is a patient centered care. You have to always be very careful about social, cultural and religious issues. Now I had to explain you about signposting. So what is this signposting? Like if I enter a role player station, so I cannot I'm not going to take her interview. It is a communication, and this role player, she should know that what I am asking to her. Okay, so before asking any information from her, I will give her some signposting, so she will understand that what I need. For example, when we start a station information gathering, in the beginning, what we say, I would like to ask you a couple of questions to gather more information from you. Will that be okay for you? She'll say yes. So this is a signposting. So now she understand. Now the few questions about problem will be coming. So this is signposting. Again, this is one example of the signposting. Again, you have to take role player sexual history. So you cannot ask directly about my sexual life or role player sexual life. You have to give some warning or signposting, then only you can ask somebody's sexual life. So for example, I would give you one example. So what you can say, I would like to ask you, some personal question that may be uncomfortable and embarrassing for you, but that information is essential for me. Will that be okay for you? She'll say yes, doctor. So if you are signposting and if you are being polite, she know you what the questions are coming, she will give you answer. So this is the signposting that you have to do in the station, and it is must, because it is not an interview, it is a communication, it is your patient. She should know what type of questions are coming. So just giving them briefing that you are going to ask this is the signposting. Now again, this in the worst domain is information gathering. Now you will say, why? We are taking histories from UG days, PG days. Why this information gathering is so bad? It is so bad, friends, because if you are doing your history taking very well, if you are speaking about investigation very well, and if you are speaking about examination very well, so you have to do this much to gain complete 2 marks in information gathering. So why it is a bad domain? Because the people will start station and whole 10 minutes, they will keep on speaking about history. Or some of the candidates, they in 10 minutes they will reach till examination. So it is a time consuming domain, and marks are only 2. So if you have not planned smartly your approach according to time, your station, then you can't complete your station. And if you're not able to complete your station, then your communication with colleague and applied knowledge domain, that domain you won't be able to gain marks, because you have not treated that patient. How you will get marks on applied knowledge domain? Therefore this information with gathering domain, you have to do so much to gain marks. Therefore it is a very therefore it is not a good domain. But we have to take information, so we have to do our work smartly, and we can divide our station. And history taking should not take more than 4 minutes, and we have to train by doing practice that way only. So in 4 minutes of the station, you will be taking history. Next 1 minute for explaining her condition, investigation and examination, 1 or 1.5 minute. At 6 minute or of the station, you have to start with the management options. So 3 minute you will be doing management option, and last 1 minute it would be for your closing of the station. So this way, smartly, politically, you have to do a station, then only you'll be able to complete and you will be able to cover all the domains. What is a pitfall in the information gathering? You know, asking irrelevant question. So you are asking me question that makes no sense in the station. For example, like I am a postmenopausal woman, and you are asking me menarche. Doesn't make any sense. That is an irrelevant question. Asking closed question, so you will not get complete information out of me. Then you're not listening to my answer. What I said, you're not listening. So you won't be able to do good information gathering. And you're repeating question again and again, same question you are speaking again. So that is again no, you're not going to gain good marks in the information gathering. And your role player, these role players are sitting and they will give you some clue. Maybe you don't know where the station will go. So every 2 minutes you have to ask, am I making sense? Is it clear? Like am I able to make you understand the things? So if you are going in any wrong direction, so this role player will, to bring you back in the station, she will give you some clues. If you are not able to take her clues, you are going to do bad in that station. So these are the few pitfalls or mistakes that people do, and I have myself seen. I'm being to the examiner in RCOG courses of Delhi, so I have seen people making all these mistakes. So please, people, train yourself. Any one of you have to ask any question in information gathering, or should I move ahead?
Clear, ma'am.
Okay, so now we have come to last domain, that is the applied knowledge. Applied knowledge, everyone know what is applied knowledge. Applied knowledge is the making the management plan of the patient. So these things are this will you have to cover to to gain marks in applied knowledge. Interpretation of the clinical finding. Sometimes they will give you a picture, for example, in vulval sclerosis station. So you have to find it. You have to find it out, and you have to explain to this to that role player. So this is the interpretation of the clinical finding. In exam, if we need not to do examination, okay, no examination you have to do to a role player. You have to just bring that in the station, that I would like to examine you. So if she has some examination finding, so she will hand over to you. Okay, so really you need not to examine this role player. Then interpretation of investigation. They will give you some FBC report. They will give you some ultrasound scan, and then you have to kind of do the interpretation. For example, I can tell you, there was a station of H-mole, and they never mentioned H-mole anywhere. Only that ultrasound scan with a snowstorm appearance was there. So you have to do the interpretation. Then you have to speak to the role player that what she's having. So this is interpretation of investigation. Well organized management plan. That is the, you have to make a management plan to this role player. So if you do all three things, so you will get marks in applied knowledge. Then before you give any management plan, these are the points you have to cover. So it is a holistic approach. Like if I have come for a pain and I'm a single mother, you have to give me treatment for pain. Also you have to give me support because I'm a single mom. So this is holistic approach. Always give options, or there will be options. You give them options, you give them risk and benefit, and accordingly you give responsible possible reason for everything, justify everything. Then they will choose that. it has to be patient centered approach. You have to like same care plan cannot be the cannot if the two patient for HMB are there, so management plan cannot be same for both of them. So you have to modify it according to patient need, and whatever the management plan you are giving to your patient, it has to be your guideline. So in applied knowledge part, it is not that you have to bring all the guideline in the answer. It is only that particular relevant, maybe one or two lines of the guideline that will help in managing your patient. Okay, so this few things you have to make clear before you make a management plan. What is the pitfalls, what are the mistake made in this patchy knowledge. This is the very important. Previously, within a month of part 2 exam, this OSCE used to happen. So that time theory knowledge for candidates used to be fresh. So these days, because of this 4 attempts, candidates are giving part 2 in some time, maybe after 6 months or a year or a 2 year, they are appearing for part 3. With you can't retain your knowledge for 2 years or 6 months or 1 year. It is tend to you'll keep on forgetting the things, so your knowledge will become patchy. So once and this corona has added more patches to knowledge for everyone. So you have to keep updating yourself. You have to keep revising your guideline. For part 3, that complete guidelines like we used to do for part 2 is not required, but a summary of recommendations, some tables, that part is required. So like right now we don't know when the exam will happen, but whenever you start preparing for the exam, like if you're reading HMB, if you're doing station for HMB or fibroid today, just go through that nice guideline again. That will take 10 minutes, but you know that your knowledge patches will be covered. So this way, whatever the station you do, please go through superficially, not in very much depth. Please check your guideline again. Okay, so you have to fill up all patches. Scattergun approach, this is again a very important thing, and I've seen candidates doing that. What is the scattergun? Like for example, you have actually you have to first you have to take history, then you have to examine, then you have to explain investigation, then you have to do management plan. So this is an organized format of an station. But some of the candidates, so they will start examining the patient, and they will start speaking about management plan. All of a sudden they will remember something, and they start taking history again. So this approach is a scattergun approach. In OSCE, if you bring any point in the answer, you used to get marks. But for part scattergun approach in part 3, you won't get marks. You have to show your organization. You have to have a real planned and organized candidate. Okay, so again, pitfall, you are not applying that relevant part of the guideline to the task. You are keep on speaking about the guideline. You're not understanding associated comorbidities. Okay, you're not listening to her wish in her care. So like she wants surgery and you're speaking about medication, or she want medication and you're speaking about her surgery. So if you're not listening, for example, if an abortion station comes and you're speaking about medical abortion, and you're not listening to this patient, but she wants surgical abortion. And if you don't explain surgical abortion, and you explain everything very nicely about medical abortion, you're not going to gain any marks there. Why? Because in the RCOG answer sheet, marks will be only awarded if you speak about surgical termination. So you have to listen to her wish, what she wants. And what she wants, you have to explain that. It is very simple. It is nothing like you have to keep her in her management involved. She will guide you what she wants. Okay, what are the sources for applied knowledge? You already know, nothing new. GTGs and or RCOG pills. nice guideline, even the nice guideline has got pills. Okay, if you search on the internet, you will find information for public, and that will be nice leaflet. Consents, clinical governance guidelines, talks, few talks. Complete knowledge of talk is not required. Okay, nobody can read so much talks. Only few important talks you have to do. NHS, some of the information leaflet you will get at NHS website. Strategy, you can't do whole strategy for part 3 exam, but there are certain case studies in the strategy. Okay, those case studies you have to do because Viva can come, or even the role play station can come. You can't go in this exam without updated knowledge of Embrace. Embrace you have to read before you go for the exam. So this is a real important. So these are the sources for applied knowledge that you have to you have to do that. So that's all about applied knowledge domain. So anyone of you have got any question can ask me.
No, ma'am.
Okay, now the station overview. Okay, so it is so everything is too much organized and planned. So there is certain framework of consultation. So this is a framework. The same we are doing in our clinics also. So first of all, when the patient comes, we usually say hi, hello. We do introduction. We usually initiate the session. After our initiation is done, we ask them some questions. So we gather some information. Then after we have gathered information, we just say, okay, you lie down, I will examine you. So you will do physical examination. So with the physical examination, you will come up with some diagnosis. Please explain that diagnosis. Please then according to what is running in your head, you have to arrange some investigation, and you have to give her some management. So you have to do explanation and planning. Then once this thing is done, then you will say, okay, get this investigation, come and see me back after 3 weeks. So this is kind of you are closing the session. This exam is seeing 14 patient in your clinic, nothing more than that. But everything whatever you are doing in the exam is same. It is what you are doing in your clinic. So this is the format you do in your clinic. Same format from top to bottom they want in the exam. Now, before you start a session, you have to have a complete information. So you will get that information from referral letter and notes. And in the exam, you have a station, 4 or 5 pages. You have to read that and you have to find that information. Now, whenever you are gathering information, so there is a structure for that as well. You have to ask three type of questions, and they really look at it that how many open-ended question you have asked. So there are three type of questions: open-ended questions, probing questions, and closed question. Now you have to understand what are they. So open-ended question. So open-ended question are the kind of question that if you ask a open-ended question, she will speak out all her story. So like she is giving you all the information she had in her role player script, and you will get most of the information for your station by asking this open-ended question. So this open-ended question allow the woman to tell her story completely. She can choose like what she has to say and how she has to say. She can give her ideas also about her disease. Okay, she may say, I think I'm smoking, therefore this is happening. Okay, so this is the her ideas also will come up. So you have to start your station or information gathering with the open-ended question. Here are the certain example, like many ways this open-ended question can be asked. So usually open-ended question will begin with, can you tell me more about your problem? Okay, what bothers you most? Can you describe your problem for me? So she will speak everything out of it. Or if you are getting referral letter, so you can start with this open-ended question. Okay, I have read a referral letter from your GP, but it would be of help if you describe your problem in your own words. why you have come here today. So these are the open-ended questions. So if I'm asking you, okay, can you tell me why you are here today? So you role player will speak everything about her problem. Okay, so these type of questions where she has to speak a lot, she has to give you full information, is the open-ended question. And in the history taking, you have to plan at least 2 or 3 open-ended question you have to speak. Now, probing question, that you are probing into the problem. So if I've got a chronic pelvic pain, so you will ask me, okay, can you tell me what makes your pain better or what makes your pain worse? So you are probing into the problem. So these are probing question. Usually this probing question will come in the middle of the consultation or middle of the information gathering. Then there are closed-ended question. So closed-ended question are the you have to end your information gathering with a closed-ended questions, and the answer will be yes or no. So okay, have you taken your medication? So she will say yes or no. Have you got your periods? Question will be yes or no. So this type of question where the answer is yes or no is the closed-ended question. So whenever you are doing information gathering, you have to do the information gathering with a blend of all 3 types of question. So you will start your station with an open-ended question, probing question. You will dig into her problem, that will come into the in the middle of the information gathering, and you will end information gathering by the closed questions. So your information gathering is a blend of all 3 type of questions. And whenever you are doing a station with your friend or your study partner, please ask her that how many open-ended question I have brought in the station, or you yourself have to keep that count, because examiners are looking for that. So now I have to speak about the so 2 types of stations are there. These are obstetric stations and gynae stations. So in obstetric stations, so what they want from us in the history, so this is the RCOG expectation. So in obstetric history, we have to complete all these points. Okay, age, BMI, period of gestation, presenting complaint, history of presenting complaint, history of index pregnancy. Okay, current pregnancy, history of past pregnancy, any medical problem, past surgical problem, drug history, family history, and social history. So this is from the strategy. This is the RCOG expectation, that in obstetric history station, you will you will bring all these points. So, we can do it in a template. So this is the general obstetric history template. So like you will ask whenever the patient come, we always ask about the present complaint. So we will start our station with the present pregnancy complaints. So details you have to take about this pregnancy, first trimester, second trimester, and third trimester. Okay. Then if she's a multigravida, you have to take history of past pregnancy details, where the same kind of complaint had happened, what type of mode of delivery, what was the baby outcome, any complication, and how's the baby doing. So these are the past pregnancy details. Then if you many stations, when they are coming for the birth options, you have to ask about the future pregnancy. So the obstetric station, this is PPF, present pregnancy, past pregnancy, future pregnancy. So if you have done your PPF, your obstetric history will be complete. In obstetric history stations, you have to speak about obstetric history. This obstetric history you have after completion of that, it will come the gynae history. So gynae history in obstetric station not very much important, but if the first trimester patient is coming, then you have to ask about LMP. For example, if a 28 weeks stage patient is coming, or 32 weeks station patient is coming, weeks patient is coming, you will not ask about LMP. So you have to kind of judge. If any bleeding patient is coming, you have to ask about smear. So you have to judge what type of how much gynae history you have to take in obstetric history station. After this pattern of the station is same for gynae and obs. So you have to ask about medical history. In medical history, you have to ask about current medication, past medication. Allergy is must, allergy is a killer. you have to bring all station. Then you have to ask about surgical history, relevant family history according to your station, and social history. So social history, so much you have to speak. You have to know, ask about smoking, alcohol, drugs, occupation of the patient, because some occupation thing will come in the related to pregnancy. You have to ask about support, whether she's a single mother, single teenager girl, old patient. Accordingly, you have to offer them support. You have to identify domestic violence. You have to identify mental health, and it is important to know their height weight ratio as well. So this is the obstetric history template. And 3Ds are important in obstetric history: domestic violence, depression, and DVT. So we always keep on doing DVT risk assessment. So these 3Ds you can't miss out in an obstetric history template. So in obstetrics like stations, there are 7 modules. So you will find this basic obstetric history template will be same. This format will be same, but according to the module, and few points you have to add, like if early pregnancy module station is coming, so present pregnancy complaint will be different. So if the maternal medicine module station is coming, then this present complaints or pregnancy complaints will be different, because you have to add on the medical details of the medical disease also. Okay, so basic format remains same. These are the points we have to cover, but according to the domain, some additional points we had to add. And so this is the history template, and investigation, examination, and applied knowledge. We cannot make a template. It will depend from station to station. So is it clear about obstetric history template? Okay, second stations will be gynae stations. So these are the points they want to cover. This is the RCOG expectation. This is from the strategy. You have to ask about age of the patient. You have to speak about presenting complaint. You have to speak about present complaint. You have to do systemic inquiry. Like in gynae station, if bowel bladder will always ask, because these are neighbors to uterus. Okay, and if any other systemic inquiry is required, like you have to speak about chronic cough and or asthma in stress incontinence station. So whatever the systemic inquiry you have to do, you have to do it. Past gynae history, obstetric history, past medical history, past surgical history, drugs, social, and family, these are the same. Okay, so how we will fit all these points in our template? So this is a gynecology station template. So you have to ask about present. Every time we have to ask about present complaint. Okay, so we have to take the details of present complaints. We have to know the aggravating factor, relieving factor, duration of the onset of the problem, duration of the problem, and very important, should not forget about the how her condition is affecting her quality of life, because UK people, they look for this. Okay, then if same complaint had happened in the past, or if she has taken any treatment, so history of that. So this is the gynae station. So you have to take gynae history in details. So you have to take about LMP. You have to know their menstrual history. You have to ask about smear. If she's a reproductive age woman, please ask about contraception. And if you are dealing with the menopausal patient, please ask about the menopausal symptoms. So from here till here, so you have to speak about everything for the gynae history. So in the gynae station, we will do gynae history first. This gynae history will be followed by obstetric history. Obstetric history, what in which station you have to ask, it will vary. For example, details of obstetric history will be required in prolapse station, stress urinary incontinence station. Okay, because with the difficult deliveries, with the heavy weight babies, all this will be the like contributing factors. Maybe in any other history, details of static history will not be required. So that we really have to assess from station to station. Then medical, surgical, family, and social. So this part of the history remains same for both of this, both gynae and obstetric. In medical, you will ask about current medication, past medication, allergy is must. surgical, family, social history points are same, in gynae station. Please remember about the differential diagnosis. If you are clear that you are dealing with the like with vulval, if from your station you already know that this patient has got vulval sclerosis, then also you will not only speak about vulval sclerosis, you will make differential diagnosis of all vulval problems, and you have to really rule out that. So please keep this differential diagnosis in the mind. Then so after history we'll move on to examination. You have to bring chaperone in the picture. If you want to do PA, PV and PS, you can't do it. You have to explain it to role player why you are doing that. If you don't explain why, no marks. Investigation, then you have to arrange some investigation. Whatever the investigation you want to arrange, you have to give reason. Without justification, role player station, examiner station, you will not get marks, even if you are speaking it out. Not overdoing. You can't do so much of investigation. Why? Because NHS, it provides free care. Okay, it provides free care to all of the patients. So a government will be paying for everything. Okay, so you can't also, you have to really judge what investigation is must. That only you have to do. And like interpretation of result, that I have already explained. So if they have given full blood count, you can't say hemoglobin is 9. You have to say a full blood count showed patient has got anemia, thrombocytopenia. So this is the interpretation of results. Again, so if ultrasound scan is given with a snowstorm appearance, you can't say scan shows snowstorm appearance. You have to say it is a picture of complete mole. So these are the interpretation of the results. So in the examiner station, usually you have to do the interpretation. After investigation, it will be the management part of the station. Whenever you are coming to management part of the station, please give them all options. So usually options will rotate around lifestyle or conservative, medical option or tablets, or it will be surgical. Whatever your patient you are getting, please give them all options. Please explain the risk and benefit, balance the risk and benefit, then ask to that role player. So what, these are the options and these are the good and bad things about it. So what is your choice? So she will choose one and you will explain more about that. That means you will support those patients in making their decisions. So this way the management, shared management plan is done. Then after, now the management is done, then you have to close that consultation. You have to say bye to this patient. So what you will do before saying bye, and this carries a number of marks. So you have to give a clear action plan of management. So when I am a patient, when I move out of your clinic, I have to know that what the doctor has said. Like doctor has said I have got bladder pain syndrome, I have to take paracetamol, and after 3 months I have to do fluid management, and I have to come back after 3 months. So this is my management plan. So I have to know my clear action plan of management. Okay, so you have to make it clear. Therefore they always say clear action plan, clear action plan. So this is a clear action plan. She should know what she has to do, and she has to understand also. Okay, and you have to always support them with the written information. So you always say, I'm giving you a leaflet to read, please go through it, and if any question you can call me back or you can ask next time. Always give them follow-up appointment if it is necessary for your station. And if your patient has come from the GP referral letter, please communicate to this GP back. So this way you will close the consultation. So these are the basic steps of the station. So we just, whatever I'm speaking are this step that I have sum up in this slide. So we start the station with introduction, name, role, place, shift, and confirmation of identity. This we have to do in introduction. After we have introduced to us to our patient, we'll make some agenda. What is this agenda? This agenda will bring her idea, expectation, and concern in the picture. So an agenda, you will form an agenda that what you and that role player are going to do in next 10 minutes. So you set an agenda. Now next step will be information gathering. You are taking history. After that you will examine this patient and you will arrange for some investigation. So then you will make for some management plan. Then you have to do the close the station, say bye to this patient, make a clear action plan. So these are the steps of a role player station. And it is just like a mathematics, and all five of all steps of the all 6 steps of the station, it is common for every role player station. And you have to follow this pattern in an organized manner. Okay, so you have to complete introduction, complete agenda making, complete information gathering, move on to examination, complete it, move on to applied knowledge. Once everything is done, just please close the station. So they want this organized approach. They're not looking for any scattergun or haphazard approach. So this is the steps of station, and this we just saw before also. So this is the expectation of RCOG in any from the candidates in the exam. So these are the steps formed by RCOG. These are the station steps that we can do so that our COG expectation is fulfilled. Is it clear?
Yes, ma'am.
Okay. Now, this is just like what they say. You have to begin the station with non-verbal clues. Smile, open you have to smile. Okay. If it is not a breaking bad news station, you have to smile. You have to sit with the open arms. You have to lean forward. You can even touch them. You can do handshake. You have to make eye contact and you have to nod. So begin the station with non-verbal clue. This is best approach. This is explanation of B. E is established information gathering with informal talk. S is support with emotional channel. T is terminate with positive note. Okay, give them follow-up plan, give them clear action plan, give them leaflet. So this is the best approach for the station. Now, at the end of the consultation, we want our doctor to be happy and also a patient to be happy. And in the exam, we want role player to be happy and student to be happy because you have done well and you have passed the station. Now, so this that's all about station overview. I'll be just explaining you some small tips and tricks. So, okay, when you enter in the exam, so you will be handed over a paper, no, not a paper, a small booklet, and there will be a pencil. Okay, so that will be only your lifeline in the exam. You have to very politically use it. So whenever you enter, so there will be a standee, your station will be written there. You have to read a station, you have to read that station. After that, you have to make management plan, and you have to make a nice management plan that what you have to cover in that particular station, that will give you pass mark. So you have to make a key, or you have to write down a key what you have to do in next 10 minutes inside the cubicle. So what a person will put in the 2-minute key outside will be different for everyone. So I have what I will put in my answer 2-minute key, I have written here, but you can change it. So you have to plan your station, make your key, and then only you'll be able to do well in the station. Because in the tension, the things will go haywire, where if you're not planning, you will not cover all points. Maybe till investigation you will reach and your time bell will ring. Okay, so what you have to judge, you have once you read the station, you will find out whether it is a happy station or a sad station or a breaking bad news station, or like what type of station is there. So you have to judge the station with what face you have to go inside, with a broad smile, with a smile inside, or you have to go with a serious look. So it is the situational awareness. You have to do that because the clay examiner is looking at you. You have to see your position. Sometimes in some station you are ST5, in some station you are consultant. So please find out who are you, because even I have made mistake. In one station it was a consultant, and I thought that I will be ST5 in all station, but thank God that was in RCOG course, so I had time for correction. Now shift, whether you are working with a morning shift and evening shift, you have to find out which clinic you are. You are in urology clinic, fertility clinic, you are in colposcopy clinic, antenatal clinic, accident and emergency, and labor ward. Because when you do introduction, so you have to have all this knowledge, because every 10 minutes your place of work, your shift of work, and your position is changing with every station. Please write it down, because you will not remember this inside. So I will write this. Then I will write on what I have to write on the paper. So I will write name of the patient, because in the station at least 3 to 4 times we have to take the name of the patient. Okay, and name is changing, every 10 minutes you can't remember it. So people, please write down the name. Please write down the age of the patient, because role, maybe this station is a 40 years old woman, but only 20 years old girl will be sitting inside the cubicle. So please write down the age. BMI is must, because there was a station where this patient has 39 BMI, and she has got some medical syndrome also. So like Charcot Marie tooth disease was there, and people made mistake that that station belonged to Charcot Marie tooth. But no, people, that station, that female has a BMI of 39, and that was an obesity station. So BMI is really important. Make diagram. The moment the moment you start, they will give you a paper and pen. Like I said, you have to make a diagram. So wherever it is, there is a possibility of making diagram. Please make diagram. You can make any rough diagram, because you are not a artist who can make good diagram. So make any diagram, just to try to make this role player understand. Lay examiner will, the moment you make diagram, lay examiner will be pleased, she'll give you marks. Okay, then please read out your task very easily. So read out history, whether they want detailed history or focus history. If it is a detailed history, you have to speak every line, but if it is a focus, you have to take little history that is related to your task. If they have written, you have to explain this investigation to this role player, so you have to explain that. And if you miss that explaining ultra USG to that patient, you will not get marks, because you have not done your task. If your task is there, answer her concern. So you have to ask, so what bothers you most, what are your concern? She will say something and you will answer that. If you're answering her concern, you will get marks. Management plan. Okay, so uh, in the first slide you will find that you will get marks if you take focus history, answer her concern, make her management plan. So you have to write this in your 2-minute key, that what I have to do inside to gain marks. Okay, so this is a planning. Then please check on the domain. So information gathering you will never miss, because you will start station with information gathering. Communication you will never miss, because you are communicating. Applied knowledge part you will never miss, because you are doing management plan. And you will never miss patient safety, because it is universal for all stations. Most common domain missed is the communication with colleague. So just look inside your station. If the communication with colleague domain they are marking, okay, especially, please bring all communications. And what all communications you have to bring, I have already discussed. So this is a planned way for 2-minute key. Okay, and exam is far, I know, but it is not that you have to do this only inside the exam. Whenever you are doing station with your friends also, please make out answer key, 2-minute key, because you have to develop that habit of making 2-minute key. So make your 2-minute key. in your with your friend also, then you will have develop a habit of making this key. Your life will be easy because you are a planned and organized person. When you go inside, so you know that what you have to do in the exam inside 10 minutes. So these are the points that I will cover in my answer key. But according to according to your according to your own needs, according to your wish, you can do some addition or deletion in this 2-minute key. But start making it when you're doing practice with your friend, because all of a sudden under the stress of the exam it will not come. Now, role player stations, I said, is a real important station because 7 domains are tested. 4 domain will be tested by clinical examiner, 3 domain marking will be done by lay examiner. So one station, it carries 14 marks. So you have to do real well in role player stations. Again, this part I have already done. So you have to make eye contact, you have to actively listen them, you have to show empathy, and you have to show them support. So these are the few tricks for role player station. So where support is required, if you find a teenager girl, single mother, your patient is a smoker, a drug abuser, any issues with domestic violence, old age woman living alone, for example, in a prolapse station, you will find her, or of any safeguarding. So these are few things you have to bring in. Now, this case-based discussion, only 3 to 4 domains are marked. So if 3 domains are marked, it will carry 6 marks, and if 4 domains are marked, it will carry 8 marks. So in case-based discussion, there are less marks, but in these stations, it is difficult to gain marks. Why? Because clinical examiner is sitting, and you have to be real perfect, and they are completely checking your knowledge. Okay, so you have to show your knowledge in this exam, in case based discussion. So you have to really plan it. Okay, because for example, APH station is there. So examiner will ask you some question, so you have to answer his question. It is not that you will keep on speaking about what you know about APH. So it is real important, and they are showing you, you have to show your knowledge here. Okay, in role player station, less of knowledge, more of communication. In case based discussion, viva station, it is more of knowledge, less of communication. So people say part 3 exam is only communication. I would not say this. This is communication plus knowledge both. Then in the case-based discussion, you will start, hello, I am Priyata, and this is my candidate number. Then if topic station is there, so I will speak a few lines about importance of a topic. Then I will say I'm ready for discussion. Then he will ask me some question, then I have to listen that question and I have to answer that. So major mistake that is done in case-based discussion, that when he will ask first question, and about like if station question has been asked about hyperemesis, so what the candidate usually do, they keep on they keep on speaking whatever they know about hyperemesis. No, it is not like that. You have to listen to his question and please answer his question, then only you will get marks. They are not judging your knowledge about hyperemesis. You will get marks only when you answer what the question they have put, and understand their question, and please answer it. The case based discussion, therefore these are difficult stations. Now because you have got exams are away, and you have to start reading leaflets. Reading leaflet is one thing, and putting them in the station is another thing. So I will just brief you how you will put leaflet in a station. Okay, so that this way you will practice, the things will be easy. You can make hand notes, or you can just do marking, whatever the way you are comfortable with. So I will give you example of the ectopic leaflet. So now So when we start the station, we start with the information gathering. So if our station of ectopic pregnancy is coming, so these are the part of the leaflet, okay? We asked in information gathering, any pain in your tummy, any bleeding, spotting, pain at the shoulder, any upset tummy, and do you feel sick, or any collapsing is there? So these are the these are the symptom inquiry. This part of the leaflet will give you idea about the patient symptoms. Then we have to make differential diagnosis. Usually in early pregnancy station, differential diagnosis will be ectopic mole miscarriage, PUL, gastrointestinal, and urinary tract. We always do inquiry. So this, we will keep this differential diagnosis in the head, and we will look for the risk factor and differential diagnosis. So this part of leaflet will give you what you have to ask in the risk factor. So any previous do you have any previous operations on your tummy, or any have you taken any treatment for any STI, or have you used, what type of contraception you are using? So this pregnancy, was it a spontaneous contraception, or whether you took any treatment, or any smoking? So this way, if you do this way, you are bringing all risk factors of ectopic pregnancy in the answer. So you have to put this in the information gathering, this part of the leaflet. Once information gathering is done, now you will examine this patient. So what you have to examine, that will that you will get from this part of leaflet, that I would like to examine you in the presence of a chaperone. If you allow me, I would like to check your tummy, because what you have to see, and if you want to have a vaginal examination, then you have to speak about that. So this part of leaflet will explain examination. Then after examination, you have to bring up in investigation. Now what investigation you have to bring? Either it will be urine pregnancy test, it will be jelly scan, it will be blood test for pregnancy hormone. So whatever is relevant to your station, you have to bring in the answer, and this part of the leaflet will help you in finding of investigation. After investigation, uh, you have to always speak and explain them clear diagnosis. You have to draw a diagram. So if ectopic patient leaflet is coming, sorry, station is coming, please draw this uterus, please draw this uterus, please explain them what is ectopic pregnancy, and please like speak about some numbers also. And if you are not like, you can't remember numbers, too much number are not required, but the numbers those who are in leaflet, if you bring them, that will be good thing. But if you don't remember any number, then also it is a not very problematic thing. You can just say to role player, I'm not good with the numbers. Okay, so this part of leaflet will help you in explaining in a clear manner how would you explain uh, ectopic pregnancy. Then towards the end of the station, you have to discuss her options. Now options will end up in three things. Either your station will be fit a station for wait and watch, so explain wait and watch. Either your patient will be fit patient for medical treatment, explain medical treatment, so all this much you have to explain. Or your patient will be a patient for surgical management, so you have to explain this part of the leaflet. So this way, you it is not just reading leaflet like a novel. It is reading leaflet and putting them in the format of the station. Okay, so it is your choice, like how the what the, some people they make some summary of the leaflet, putting this leaflet in the broad headings of information gathering, examination, investigation, and applied knowledge part. And some of the people, they will just read leaflet like they will put highlights. Okay, so the different people have different methods of treatment, but this way you will bring your leaflet in the role player stations. And whenever you are doing your the practice with your partner, please if you are dealing with discussing a topic station, please open up that leaflet. Okay, because you will stuck somewhere in the station. Immediately you look at the leaflet and you will find the answer how to explain that to a role player. So this way, like, leaflet can be applied to the station. Now, and anything now, how to prepare. So ideally you have to have a two study partners. Why? Because so much of hassle is there these days booking the exam, because they have got more number of candidates and less number of seats. So maybe you get in the exam booking and your partner doesn't get. So what you will do in last 1 month, if your partner is not giving exam, she will not read, you will be left alone. Better thing to have two study partners. Then please do station 10 minutes. Keep on Don't keep on speaking for minutes together, because you have got only time of 10 minutes. Whenever your role play when friend is giving feedback, please ask for the feedback in the domains. What I missed in patient safety, what I missed in applied knowledge. You have to train your brain according to domains. Then if you train according to domains what I have to cover, then it will be easy passing exam, because marks are also given according to domains. Okay, so we have to understand their expectation from us, then only we can pass this exam. Then history, please don't keep on history for long time. So it will be for designed 4 minute for history. You have got plenty of time, but you can do one or two station from now. Once your exams are announced, please do 4 to 5 station per day. 1 month before exam, please do 8 to 10 station per day. You have to do at least one online course, because you have to practice it, and also you have to prepare for it. Then you have to do one on sport course. That means at least 2 weeks before, you have to feel that pressure of the exam. So you have at least to do one on spot course. Okay, better if you get booking for RCOG course. But if you're not getting booking for RCOG course, please go for any on-site course. But you have to, please don't go appear in the exam only with your preparation. No, it is, you have to go through real exam situation before you appear in the exam. For example, before I went to exam, in 2 weeks or 15 days before my exam date, I did two courses. So when I so I there so I felt that pressure. And when I went for the exam, so to me, I was already tuned to that pressure, so I didn't feel pressure in the exam. So it is important to do one on-site course or on-spot course also. And real important is part 3 is communication. You have to have a study partner who can give you constructive feedback, what you missed, what improvement is required. Okay, so with all this, so it is I thank you for joining. And next course will be coming for May exam, will be starting from December, maybe second or third week. So those who are interested, they can send me a message, and you can subscribe. I keep on taking classes for part 2 and part 3 as well, so you can subscribe on the YouTube channel, so you'll be getting updates. And 12 13 stations are already there on the on website, Mission MRCOG website. So you can listen to those stations, so that will help you in getting some of idea. Okay, so any one of you, I'm open to questions now. Any one of you have got any